Hi everyone, my name is Ruby Ingrassalino, and today I'll be talking about imposter syndrome among medical residents, why it occurs, who it affects most, and how it can be addressed through a structured, evidence-based intervention. This presentation takes a human-centered approach because imposter syndrome isn't just an abstract concept. It reflects the lived experiences of many trainees navigating one of the most demanding phases of medical education. I want to begin by emphasizing that imposter syndrome is not about a lack of ability. Many residents who experience these feelings are highly capable and objectively successful. What makes imposter syndrome especially challenging is that it often remains hidden. Residents may appear confident and competent on the outside while experiencing significant self-doubt internally. What is imposter syndrome? Imposter syndrome refers to persistent self-doubt and difficulty internalizing success, even in the presence of clear evidence of competence. Individuals experiencing imposter feelings often attribute their achievements to luck, timing, or external help rather than their own abilities. Importantly, imposter syndrome is not a clinical diagnosis, but it is a well-documented psychological phenomenon. It tends to emerge in high-achieving environments where expectations are high, feedback may be inconsistent, and social comparison is constant. Residency training includes all of these conditions, which is why these feelings can become particularly intense and persistent for medical residents. Medical residency is a uniquely high-pressure environment. Residents face long work hours, ongoing evaluation by supervisors and peers, and emotional demands related to patient care. They are expected to perform at high levels while still learning, and often with little room to show uncertainty. This combination of constant evaluation, emotional strain, and limited autonomy creates an environment where self-doubt can easily develop. Even minor mistakes may feel amplified, reinforcing the belief that one does not truly belong or is not competent enough to be in the role. Research suggests that between roughly 1/3 and nearly all medical residents report experiencing imposter feelings, depending on specialty and measurement method. These feelings are not benign. They are associated with increased anxiety, burnout, emotional exhaustion, and reduced well-being. Over time, this can create a harmful cycle. Residents may over-prepare, avoid asking questions, or push themselves to unhealthy limits while still feeling undeserving of their role. This lack of psychological safety can interfere with learning and professional growth, especially in a field where asking questions is essential. While imposter syndrome affects many residents, it does not affect everyone equally. Female residents and those from underrepresented racial and ethnic backgrounds consistently report higher levels of imposter feelings. These residents may also face additional challenges such as microaggressions, stereotype threat, and a lack of representation in leadership roles. These experiences can heighten feelings of not belonging and reinforce self-doubt, even in the presence of strong performance. As a result, imposter syndrome becomes intertwined with broader issues of equity and inclusion within medical training. Social psychology helps explain why imposter syndrome appears in residency. Social comparison theory helps explain why residents compare themselves to equally high-achieving peers, making it difficult to feel competent. Attribution biases further contribute, as residents often attribute success to external factors while internalizing failures. From this perspective, imposter syndrome can be understood as a breakdown in how individuals interpret feedback and evaluate themselves within a competitive social environment. When combined with identity-related pressures and emotional processes like shame, these cognitive patterns can quietly reinforce imposter beliefs over time. To address these challenges, I developed the Resident Resilience and Confidence Initiative, or RRCI. This program takes a multi-level approach to reducing imposter syndrome by addressing individual cognition, social support, and systemic culture. RRCI includes 5 components: normalization workshops, cognitive restructuring training, peer support and inclusive mentorship, systemic change, and program evaluation. Together, these components aim to reduce imposter feelings while promoting resilience, belonging, and psychological safety. The first component focuses on normalization and destigmatization. Workshops introduce residents to imposter syndrome, present data on its prevalence, and emphasize how common these experiences are across medical training. By hearing peers and faculty openly discuss their own experiences with self-doubt, residents are less likely to view imposter feelings as a personal failure. This use of social comparison helps reframe self-perception and reduces shame. For Component 2, the focus is on cognitive restructuring. This targets the negative thought patterns that maintain imposter syndrome. Skill-building sessions are added to the existing didactic curriculum to help residents challenge negative thoughts by identifying their internal narrative and evaluating the evidence behind it. Training also emphasizes building self-compassion, allowing residents to replace harsh self-criticism with more kind and realistic self-appraisal. Over time, this process helps residents to internalize their successes rather than attributing achievements to luck or external factors. The third component emphasizes structured peer support and inclusive mentorship. Peer support groups provide safe spaces where residents can share experiences without fear of judgment. Hearing others articulate similar doubts helps residents realize these feelings are common rather than indicative of inadequacy. Mentorship, particularly when mentors share similar identities or lived experiences, reinforces belonging and provides validation. Together, these relationships help counter isolation and strengthen confidence. Component 4 shifts the focus from the individual to the culture of residency itself. In more traditional training environments, fear of mistakes, silent evaluation, and competition can unintentionally reinforce imposter syndrome. In contrast, a growth-oriented culture emphasizes learning from errors, transparent and supportive evaluation, and collaborative learning. Encouraging questions and normalizing mistakes creates psychological safety, which is essential for both learning and confidence. When culture shifts from competition to collaboration, residents are better able to view themselves as part of a shared learning process. The final component focuses on evaluating the effectiveness of the program. Residents complete validated measures such as the Clance Imposter Phenomenon Scale and the Maslach Burnout Inventory at baseline and annually. In addition to quantitative measures, confidential qualitative feedback is collected to capture residents' lived experiences and perceived support. This evaluation process ensures that the program remains responsive, evidence-based, and effective over time. In conclusion, imposter syndrome is widespread among medical residents and deeply shaped by cognitive, social, and systemic factors. However, it is not a personal flaw. It is a predictable response to high-pressured environments. Addressing imposter syndrome has implications beyond resident wellness. It affects learning, patient care, and long-term retention in medicine. By implementing interventions like RRCI, residency programs can foster resilience, confidence, and belonging, helping to support both healthier physicians and healthier healthcare systems. And here are my references. Thank you.